I'm going to talk about metabolic response to trauma, way of introduction, highlight some of the features, some of the consequences, then factors, complications. Metabolic response to trauma simply means the body's response to an insult with a view to establishing homeostatic state. The magnitude of the metabolic response is generally directly proportional to the severity of a tissue injury. Metabolic response is aimed at returning an individual to a healthy state. A major response can, however, damage some organs in the body. In modern surgery, a major goal is to minimize metabolic response to trauma in order to shorten recovery time. In modern surgery, the way to minimize response to trauma is to modify some of the surgical approach, like a minimal access surgery, like in the case of laparoscopic and endoscopic surgeries. Classically, these ones have been described as stress response, a term that is coined by a Scottish chemist called Codberson in 1932. The initial response is directed at maintaining adequate substrates or energy supply to vital organs at the expense of other non-vital organs. In some cases, multi-organ dysfunction due to the effect of inflammatory mediators and poor sustained measures during the insult. Systemic inflammatory response is a syndrome also that is associated with the body's response to the trauma or to the infection. Either hyperthermia or hypothermia. Leukocytosis rates can also increase in respiratory rates. Classification to ebb and flow phases, recovery phase. The ebb phase, which lasts for about 24 to 48 hours, flow phase, which occur in 3 to 10 days. The recovery phase, which is usually anabolic in nature and lasting into weeks. A trauma causes major alteration in energy and protein metabolism. The response to trauma can be divided into ebb and flow phase. The ebb phase occurs immediately after trauma and lasts between 24 to 48 hours and is immediately followed by flow phase, after which we have anabolic phase and finally the fatty replacement phase. Ebb phase also comprises the first few hours after injury. The individual is cold and hypotensive. Possible shock may probably occur when the metabolic response has initiated inflammatory process that may cause injury to organs like the kidneys, some of the inflammatory mediators like the interleukins, interleukin 1, interleukin 6, and then two more necrotic factors. They are said to be injurious to the kidney, leading to poor hypoperfusion. The flow phase is described in two parts. The initial catabolic phase, which is characterized by high metabolic rate down of proteins and fats, a net loss of body nitrogen. So in this case, there will be negative nitrogen balance and weight loss. This phase usually lasts for about a week or so. And then the anabolic phase, which protein and fat stores are restored, and there will be weight gain, positive nitrogen balance, which lasts between 2 to 4 weeks. Recovery phase, otherwise known as anabolic phase, body gain weight. The factors that affect metabolic response to injury, some of the inflammatory cytokines, some cytokines involved in acute inflammation. Tumor are pro-inflammatory. They release leukocyte from the bone marrow and activate leukocytes. And then interleukin 1. This is implicated in fever. Interleukin 1 has been implicated because it is known that it stimulates the term part of the hypothalamus. Interleukin 6, which growth and differentiation of lymphocyte, activation of acute phase proteins. And then interleukin 8 also, which is chemotactic for neutrophils and T cells. Then interleukin 10 inhibits immune function. Injury to a vessel, loss of we have innate immunity and humoral immunity. Neuroendocrine stimulation or factors. These are the hormones that occur in the post-traumatic period. The following hormones increase following trauma. The growth hormone, adenocorticotropin releasing hormone, somatostatin, dopamine is also increased, prolactin, renin-angiotensin. Then glucagon is also another stress hormone which helps in breaking down of the stored glycogen in the liver so that energy will be released. Histamine, the kinins, the endorphins. The following hormones are decreased after an injury. We have insulin, and that's why in the immediate post-op of a surgical patient, there is minimal insulin resistance. This is in response to release of the stress hormones in circulation. We also have FSH, that's the follicle stimulating hormone, the luteinizing hormone. Then we also have estrogen and progesterone, even testosterone, thyroid hormone T3 and T4, neuroendocrine stimulation, which will lead to sympathetic discharge, to tachycardia and increase cardiac output. Neural receptors are stretched in the carotid arteries, the arch of aorta. When the body senses that there is hypovolemia or there is blood loss in response to trauma, those receptors are stretched, leading to now release of renin, which is a hormone that now goes to the lungs, then activation of the renin, angiotensin, and aldosterone system, which will now lead to absorption of fluid from the impermeable portion of the nephron. We also have noradrenaline. These are also stress hormones. Adrenaline also. All these contribute in changes in carbohydrate, fat, and protein metabolism that occur following injury. Intervention that reduce sympathetic stimulation, such as epidural or spinal, may also attenuate this change. It has been shown that pain also is a factor. Management of postoperative pain is also very important. These are also some hormonal changes in trauma. 24 to 48 hours, physiological changes, we can see the basal metabolic rate, oxygen usage, temperature decrease, and vasoconstriction. Implicating hormones are the catecholamines and cortisol. Also the flow, and then the catabolic, which occur in 3 to 10 days, and finally the anabolic, which is 10 to 60 days, which is associated with positive nitrogen balance. We can see the anterior pituitary, which secretes ACTH, the action of the ACTH, which is stimulation of the aldosterone secretion by the adrenal cortex. Then aldosterone now, as mentioned earlier, which causes sodium and water retention from distal adrenal tubules, which aim at correcting the hypovolemia or the sudden blood loss or the insult to the body. It just glomerular apparatus also is the one responsible for excretion of renin to the liver, and then activated, and then finally leading to the retention of from the renal tubules. These are various systems, various organs as it affects changes. We can see the heart and cardiovascular system, sympathetic activation leading to tachycardia. Then the liver, we can see its effect on the liver, glycogenolysis, increase in gluconeogenesis, lipolysis, ketone body production, and acute phase reaction. So those ketone bodies that are produced during this period can also enter into TCA cycle, so that more ATP are generated. The site of injury also, we can see it will lead to inflammation, edema, endothelial activation, increased blood flow, and afferent nerve stimulation. Then in the pituitary, we have increased ACTH, ADH. Then in the suprarenal gland, we have increased aldosterone, cortisol, and adrenaline. And then in the kidneys, I've talked about this. The pancreas also, we have insulin and glucagon. Skeletal muscles, which release amino acids into circulation. Then bone, impair red cell production in the bone. Physiological changes occurring during catabolic phase. Carbohydrate metabolism, glycogenolysis, stores that last up to 10 hours, then increase hepatic gluconeogenesis also occur, and then insulin resistance in the tissue, and there will be consequent hyperglycemia in the system. Fat stores in the adipose tissue undergo lipolysis, so free fatty acids are liberated as the alternative source of substrate to maintain energy to vital area like the brain. Some conversion of free fatty acids also to ketone body, and glycerol also can be converted into glucose. Then protein metabolism, increase in skeletal muscle breakdown, amino acid is converted to glucose in the liver and used as substrate. Glucogenic amino acids. It's not all amino acids that ultimately form glucose. Have the glucogenic amino acids and the ketogenic amino acids. Various events that occurs during the trauma. We can see the basal metabolic rate 65%. Then here, basal metabolic rate is 70%. This one is the healthy sedentary 70 kg man. These are the energy requirement. Protein synthesis by the liver, which alter. We have the positive acute phase protein. The following are increased after trauma. We have C-reactive protein. We have even haptoglobins. We have ferritin. We have fibrinogen. We have even alpha antitrypsin. We have alpha microglobulin, and we also have plasminogen. So they are increased in response to trauma by liver. Then the negative ones include albumin and transferrin factors that is associated with the magnitude of metabolic response to injury. You can see various factors have been implicated, ranging from genetic predisposition, coexisting comorbidity, like people with diabetes, chronic medical condition, hypertension, suppressed, like patient on chemo, HIV and AIDS. Response to trauma may vary. Some drugs also interfere with metabolic response to trauma, like patient on chemo, steroids. Nutritional status, and how we encourage the patient to increase the intake during the exaggerated response of the metabolic response to trauma. Then acute surgical trauma-related factors. The severity of injury also is a factor. More the insults, the more the response, and at times the longer the recovery period. Changes in temperature, optimal control of pain, increase outcome of surgery. So effort should be made to allay pain, fear, and anxiety by judicious use of anesthetic or pain control. Method to minimize metabolic response to trauma include prompt placement of blood loss or fluid loss. Adequate nutrition, high protein diet is recommended. Then analgesia is recommended. So hypothermia, laparoscopy, and endoscopy said to minimize metabolic response to trauma. Some of the consequences of response include initiated the repair process and consequently wound healing. Then mobilization of substrates to supply vital areas like the brain and the kidneys. Distant organ damage. Factors influencing the extent and duration of metabolic response, like pain and fear, anxiety. So the aim is to remove pain and fear and anxiety of a patient. So liberal use of analgesic, if possible, anxiolytics is advocated in order to reduce the exaggerated response. Surgical factors, type of surgery, the duration, how many hours does the surgery last, and then the preoperative management, coexisting medical condition prior to surgery, extent of trauma, post-traumatic complication like bleeding, hypoxia, sepsis, or even repeat surgery, like patients that have wound breakdown and is being planned for secondary closure. Pre-existing nutritional status also is very important. Age of the patient, aesthetic consideration, that's the nature of the anesthesia, whether it's epidural or spinal or general anesthesia. In conclusion, metabolic response to trauma is aimed at maintaining a fairly constant internal environment by host defense mechanism in response to insults in body. Knowledge of coordinated interplay of mechanism is key in understanding how the body responds to trauma or injury. This will in turn reduce hospital stay, reduce mobility, and enhance recovery. The F phase is the earliest stage, which occurs between 24 to 48 hours and is characterized by hypovolemia, decreased metabolic rate, decreased cardiac output, hypothermia, and lactic acidosis, especially in the skeletal muscle. The flow phase, which occurs shortly after the F phase, is characterized by initial catabolic phase that occurs in 3 to 10 days and is characterized by hypermetabolic states. So some of the features in the flow phase include rising body temperature because the inflammatory mediators are already in circulation, tissue edema, increased oxygen consumption, and breakdown of body fat. So this is associated with negative nitrogen balance.
Which of the phases are similar to SIRS, and what is SIRS? SIRS. So among these two phases of the metabolic response to trauma, that is the ebb phase and the flow phase, which of them is similar to the SIRS?
Systemic inflammatory response syndrome phase has like hypothermia, and then the flow phase has hyperthermia. I know in the SIRS there's hypothermia and there's hyperthermia. It could be hypo or hyper. It could also, and then there's also hypotension in SIRS, so I think it also falls in the F phase as well. So I think maybe the F phase is more likely to be similar to the SIRS.
Yes, so the ebb phase is characterized by a hypermetabolic response, isn't it? Which is similar to the systemic inflammatory response syndrome. So how do you define systemic inflammatory response syndrome?
Response of the body to trauma or sepsis. Criteria, hypothermia or hyperthermia, then hypotension.
Fever or hypothermia, isn't it? You can have tachycardia, you can have tachypnea, isn't it? Changes in blood leukocyte count. So it serves as an exaggerated defense response of the body to some form of a stressor, to some stressor, some noxious stressor. For example, infection, trauma, surgery, inflammation, even ischemia. And so the aim is to localize and then eliminate that, that stressor, that insult.
The interleukins that are responsible for fever and pain.
Specifically interleukin 1 beta, then there's interleukin 6, and then of course tumor necrosis factor alpha. I think those are the main cytokines involved in pain. I think in fever also, they say that the platelet activating factor can also be implicated. At your outline, you outlined by beginning first with your introduction, the classifications. The classification, sometimes in some texts, you'll see it as phases, isn't it?
Yes, ma'am.
As phases and not actually as classification. So I like that last point you made, that in modern surgery, a major goal is to minimize the metabolic response to trauma in order to shorten the recovery time. So that is the main reason why this topic is being presented. We know that trauma is one of the leading causes of mortality and morbidity for, young and middle-aged individuals. And trauma can either be accidental or operative. Patient can come to you as an emergency following trauma, and at the same time, we also cause trauma by operating on our patients, isn't it? By carrying out procedures. Because of this, we know that if we don't attempt to reduce the metabolic response to trauma, there'll be a delay in the patient's recovery, and that is why we need to modify it as much as possible by various methods. The fact that trauma is one of the leading causes of mortality and morbidity. And then you also define metabolism. So what is metabolism?
Metabolism, it simply means the process of breaking down of food substrates into simpler ones so that it can be assimilated or absorbed by the body.
In an aim to do what?
In an aim to ensure cellular function so that energy can fuel the cells, so that energy can be made available at cellular level.
Energy, yes, and then other physiological responses, isn't it? Can continue. Yes. All those biochemical reactions, physiological responses, which are aimed at sustaining the life of the individual, isn't it?
Yes.
Yeah, that's the aim of the metabolic process. So it's a complex system, which results in various biochemical reactions and physiological responses which are necessary to sustain the life. And we know that this traumatic injury, it triggers many responses, isn't it, to various systems in the body. So that is why it's necessary to talk about some of these responses, in various systems of the body. The cardiovascular system, the neurohormonal system. It's necessary to return the body to the pre-injured state, as near as possible to the pre-injured state. And we know that the metabolic response is directly proportional to the severity of the injury, isn't it?
Yes, ma'am.
Yes, so the greater the injury, the greater the metabolic response to the trauma. So the greater if you're going to carry out major surgery on your patient, the greater the metabolic response to trauma. So can you mention some of those endocrine responses that we see when a patient is injured, or when a patient has surgery?
Some of the endocrine response, like mentioned, that there will be increase in the stimulation of ACTH, which will now lead to stimulation of the adrenal cortex, which will trigger the renin-angiotensin aldosterone system, which will correct hypovolemia or blood loss during trauma. Increase excretion of growth hormone, and then also increase secretion of prolactin, decrease activity of insulin, thus leading to predisposition of insulin resistance.
So there's a rise in the corticotrophin releasing hormone, ACTH, cortisol axis, isn't it? The HPA axis, which rises rapidly after the trauma. and all in an aim to maintain the energy supply. And this results in the depression of the action of insulin. That impaired cellular immunity. Of course, you have the IGF-1, which is usually raised for days. About ghrelin, it plays a role in promoting growth hormone release, an appetite stimulant also. And so and it also has a role in promoting growth hormone release. It helps to reduce some of those pro-inflammatory cytokines, and reduces neutrophil infiltration. It also helps. So it's been found that it helps to improve survival in patients that have exposed to trauma, and it's actually a positive predictor of ICU survival in septic patients. So when you're reading, you come across it in many texts, because it has been found to be a very important factor in patients that have been exposed to trauma. And of course, you've mentioned ADH, antidiuretic hormone, the role of aldosterone, of course, the increased release of catecholamines, isn't it, from the adrenal medulla, which is usually just within seconds of the trauma. So that helps to cause some vasoconstriction and maintains the energy supply by stimulating the glycogenolysis and gluconeogenesis, as well as lipolysis. Yes. So that hypermetabolism, can be measured by the resting energy expenditure, isn't it? I'm sure you came across that when you were reading. Resting energy expenditure can be increased depending on the kind of trauma the patient is exposed to. So for like major operations, things like fractures, sepsis, even severe burns, it can be as high as what? The increase in the resting energy expenditure, that is the REE, following trauma. The greater the severity of injury, the greater the degree of hypermetabolism. Things like major operations, fractures, sepsis, and severe burns, you can have the hypermetabolism increasing to as high as 100%, 200%. So the REE will be through the roof. In sepsis, sometimes even as high as 50 to 80%. Major fractures up to about 25%, even between 10 and 25%. In major operations, 10%, even higher, depending on the kind of surgery. Can you mention some of the changes in glucose metabolism, in the metabolic response to trauma?
Okay, some of the changes in glucose metabolism in response to trauma, because of the release of those stress hormones and consequent lipolysis, there will be hepatic glucose. There will be increase in hepatic glucose output. There will also be activation of the glucagon, also can lead to breakdown of glycogen stores. So as a result, then there will be hyperglycemia from insulin resistance mentioned earlier, because insulin growth like factors and growth hormones are liberated, which act in concert to cause insulin resistance. So the hallmark of glucose metabolism in the immediate aspect of trauma is hyperglycemia. They come down with hyperglycemia due to some degree of insulin resistance in the body or in the system.
The whole aim of providing glucose is to prepare the patient for wound healing, isn't it? That increased glucose turnover, is necessary for wound healing, isn't it? And for all those inflammatory cells to be released. So that is why you get some of those changes in the glucose metabolism. As you mentioned, we have hyperglycemia and even see glucosuria. Of course, because of the increased glycogenolysis, which is mediated by glucagon, isn't it? And also, yes, you mentioned gluconeogenesis, mediated by cortisol and others, the growth hormone and the rest. And yes, there's insulin resistance. So because of this, there is reduced uptake of glucose into the cells because of those counter-regulatory hormones that you mentioned. And so there's also reduced tissue oxidation of glucose. As you mentioned before, there's also of course lipolysis. And so you have triglyceride breakdown, and then you end up getting free fatty acid and glycerol. So sometimes you see that because of this lipolysis, that becomes the principal source of energy, especially if glucose is not provided after like 21 days of starvation. That is in patients who are starved. Did you say anything about changes in skeletal muscle protein?
Changes in skeletal muscle protein, that's when there would be lean body mass. There would be degradation of body protein during the catabolic phase.
Yeah, so this muscle proteolysis, isn't it?
Yes.
Yes. But there are some muscles that are spared, like what?
Heart muscles.
Yes, exactly.
The muscle in there.
Cardiac muscle, yes. That's the only one that's spared. All the rest are broken down, isn't it? Because of the release of interleukin-1 and tumor necrosis factor alpha. If the protein catabolism exceeds the synthesis of protein, you're not mediating your metabolic response to trauma well by providing the necessary nutrients, isn't it? By providing the necessary proteins, that will result in negative nitrogen balance, isn't it? And that will now cause a reduction in the weight of the patient, isn't it? Those are some of the alterations in skeletal muscle protein, and that will of course lead to what? Increased fatigue, reduced functional ability in the patient, and then of course quality of life, and of course I will now increase the degree of morbidity and mortality in the patient. How about some of the alterations that we see in liver protein? When you talk about that, the different kind of proteins, different kinds of liver proteins. Peripheral blood mononuclear cells, they reduce those cytokines, the interleukins 1, 6, tumor necrosis factor alpha. These stimulate the hepatic synthesis of the acute phase reactants, isn't it? So, but then there are some proteins that are known as positive acute phase proteins. These are released after injury, of course, and then there are also the negative acute phase proteins, isn't it? So, can you differentiate them? The positive acute phase proteins, which are released after the injury.
The haptoglobulin.
Yes. What's the more commoner one that we see? Positive acute phase protein, which is released after injury.
The ferritin.
Yes, ferritin is one of them. So C-reactive protein, because it's a positive acute phase protein. It activates complement, and it opsonizes the dead cells. And usually you see it, within 4 to 6 hours of trauma, you see it, it rises within then, and then it peaks at 48 hours. So, if you are able to measure that ab initio and then you monitor it, it can be a good indicator. It can be a prognostic factor when you're managing your patient that has been exposed to that trauma. So we have others like the fibrinogen, the alpha-1 antitrypsin, alpha-2 macroglobulin, and even the plasminogen. Of course, you mentioned the ferritin and the haptoglobin. But then you see some other negative acute phase proteins, isn't it? Like the albumin and the transferrin. Yes. So we talked about the insulin resistance. I've talked about hyperglycemia. We've talked about the decreased glucose uptake by the peripheral tissues. And we've talked about the fact that the more severe the insult, isn't it, the greater the insulin resistance. Yes. How about some of the immunological responses? Can you just mention some of that? Talks about that. Immunological changes. Because the trauma patient is susceptible to sepsis, you see diminished capacity to phagocytose, some abnormalities in the antigen-presenting cells like the macrophages, the monocytes, the dendritic cells. You have that increased lysosomal stability and reduced oxidative burst. There's an impaired antigen representation to the lymphocytes. They have a reduced lymphocyte function, a polymorphonucleocyte function. So what are some of the activators of that metabolic response to trauma?
Some of the activators, pain, and then the release of inflammatory mediators.
Some of those cytokines, the interleukins 1, 2, 4, 6, 8, 10, tumor necrosis factor alpha, isn't it? Even hypovolemia. can activate the metabolic response, isn't it? Some of those influencers of the metabolic response, those factors or influencers of the metabolic response to trauma. Talked about the severity of the injury, the nature of the injury, isn't it? Major burns gives you a higher response to the metabolic response is higher. We talked about the REE, the hypermetabolism that results.
Hypothermia.
Many of our patients are malnourished, isn't it? And how about the age?
The extremity of age.
Yes. If you're not ameliorating or modifying some of those factors that can compound the injury process, like for example, a patient has come to you with trauma. You have not stopped the bleeding, exposed to trauma, and maybe internal bleeding was not detected, and the patient is continuing to hemorrhage internally. Of course, you know that that means that you're not ameliorating the metabolic response, isn't it? So it will just further compound the injury process and worsen the prognosis. It will increase the morbidity and the mortality of the patient, isn't it? Of course, we mentioned hypothermia. If you have continuing edema, the tissue, if you're continuing to not provide enough fluids to the patient, you're under perfusing the patient. You're not giving enough fluids. You're starving the patient. Look at that patient that we saw at the intensive care unit. So the metabolic response is still ongoing, isn't it? You can see that patient is in negative nitrogen balance. Yes. So we have not ameliorated the metabolic response to the trauma the patient was exposed to, because there's still an ongoing insult. So because of that, the patient is in negative nitrogen balance. Even immobility. You're providing care to the patient. You're not modifying the patient's response by encouraging the patient to move around, to be mobile, to get up, to go to the toilet. You're not. You've not removed your urinary catheter. You're not encouraging the patient to move around, to eat, to use their hands. So you try and maintain normothermia by making sure that there's optimal temperature. Reduce hypothermia, because we know that hypothermia can also increase things like infections, cardiac complications, bleeding, and the rest, isn't it? But at the same time, while we're still giving fluids, you know that you shouldn't overload, isn't it? Don't underload, don't overload, because those can also now further worsen the patient's condition. If you try and maintain normal glycemia, regular measurements of the fasting blood glucose, isn't it? Try and reduce starvation, like that ICU patient, if possible. Give your parenteral nutrition. Look at that patient that we saw in the private ward. Provide enough dextrose, isn't it, to provide energy. Try and reduce your organ death, your organ failure leading to death. Early ambulation, as I mentioned before, because the more the patient ambulates, you're avoiding immobility, you're reducing the risk of muscle wasting, isn't it? Patient is building up his muscle by moving. You're preventing proteolysis, muscle wasting. And then as much as possible, if you can carry out some procedures, minimally, minimal access procedures to further reduce the chances of the patient, responding, in a negative manner, further increasing the metabolic response. You try and do it as much as possible. If it's possible for you to, do a minor procedure bedside instead of taking the patient to surgery by doing general anesthesia and carrying out major surgery, it's better for the patient, isn't it? You can further ameliorate the patient by giving you IV amino acids and glucose, like the total parenteral nutrition that we give the patient, isn't it? Use your appropriate antibiotics. As much as possible, do your own debridement. Drain any pus that is there. As much as possible, enteral feeding if you can. Then, of course, you can also supplement with your micronutrients, isn't it? Yes. Did you conclude? Can you just go to your conclusion?
In conclusion,
yes.
Metabolic response to trauma is aimed at maintaining a fairly constant internal environment by host defense mechanism in response to insults in the body. Knowledge of interplay of mechanism is key in understanding how the body responds to trauma or injury. This will in turn reduce hospital stay, reduce morbidity, and enhance recovery.
Okay, good.